Okay, so what we're looking at now, the session is a really important session, and it's the innovation in CLL care and hope on the horizon. Chronic lymphocytic leukemia CLL care is evolving rapidly. This session explores the latest breakthroughs and treatments, which I'm really looking forward to. We have an eminent speaker, Professor Shankara Paneesha. I hope I'm pronouncing your name right, and apologies. And if you'd like to come up, have you slides or?
Up on the system.
Up on the system, great. Okay, thanks very much. Nice to meet you.
Thank you. Do you know how I move the slides? Good afternoon. Thank you very much, and may I start by thanking the network for this kind invitation. It is a privilege and a delight to be here with you all, and it is such a moving experience for clinicians, and we have Professor Ben Kennedy in the audience. It is great how much of the success happens in the lab and the clinical trials, but ultimately for people to benefit, it is the access to the drug which is more important. And I was very impressed with everybody fighting for the access to the drug. And I think one of the agenda the network should add is how do they have access to the clinical trials, because only few countries puts patient into the clinical trials, whereas when we go through some of the clinical trials, I highlight how many of the population are missing out. With this, I thought where we are with the CLL treatment. So I know when Nick gave me a briefing, this is all about what is coming in future. But we can only hope for future if we celebrate what we have already achieved in the last 10, 15 years. So I don't know how many of you remember Donald Rumsfeld when he said in 2003, it's came across as such a odd statement, but where we are with the science and with the progress we are making in the CLL is so true. And if anybody had told us in 2005 we will have all these excellent drugs in 2025, none of us would have believed unknown is what the future holds for. With this, I just wanted to say, you all know, but just to make sure, the CLL is the most commonest leukemia, and in the lab we do some specialist tests. But the most important, you had a moving already a note from Ross. Ross will understand why he's special, because the median age for the CLL is 72 years, but only less than 5% of the patients with the CLL will be diagnosed below the age of 40. So that is why. And like most conditions, unfortunately, it's more common in men as compared to female. And the key is minority of patients with the CLL do need treatment. This is how the things will appear on the slide. Even though we are looking today for what's available in the form of the treatment, but what is most important is how can we diagnose confidently the CLL and the genetic and the prognostic markers, so that we are able to group patients and do the best treatment depending upon the genetic characteristics. And most importantly, when we are exposing patients to some treatment with side effects, we can also monitor their response and where we can stop the treatment. Just to summarize how much the community, the CLL community and the researchers and the advocates have achieved it. This is how the various treatment have been approved by the FDA going back to the last 50 years. You could see nothing much happened until the previous millennium. Come the 2000, there is a flurry of the drugs, and particularly the last 10 years, there is a excellent evolution. I don't know whether people can see this slide from the back. This is looking at the immune-based therapy, how much progress in the last 10 years, looking at various treatment. With the interest in time, we can pick up any of these in the question and answer if we do have time. But what all changed in the last 10 years with the evolution of these two fundamental pathway inhibitors? The first, which we have all been discussing, it is the understanding of the B cell signaling with the BTK and also the BCL2. These two understanding of the biology and how we can manipulate this for to better the treatment, change the how we manage the CLL today. What I have done, with the interest of time, listed here all the trials of the BTK inhibitors, starting from the ibrutinib, going up to the zanubrutinib. I'm so delighted to hear, because I've sat next to somebody from the Max Foundation who are able to now enable people in the parts of the Asia access to zanubrutinib, where it is impossible. Even Professor Kennedy may say that even in UK, we only had the access to zanubrutinib for the front line only in 2025, even though we were doing clinical trials. It's a great work from the network and the charities getting the drugs to the people. What it clearly highlights, it's the 17p deleted CLL. Before, people would have survived between 2 to 3 years. Now, with the access to drug like BTK inhibitors, we have the Sequoia study with a 5-year follow-up. Now, 75% of the patients with the 17p deleted CLL are still in remission at 5 years. So this is the advance we have made with the 5-year follow-up. It is impossible to say which is the best BTK inhibitors, because it's always difficult, but we do make decisions based on the side effects and individual patient characteristics. And when people do look at the ibrutinib, the RESONATE-2, we now have a median follow-up of nearly 10 years. So it is such a progress and the follow-up. When we look at some of the BCL2, that is the venetoclax, which have summarized here, we do have the CLL14, the 7-year follow-up, which again shows having a treatment for only 12 months, 1 year, 50% of the patient will be not needing any treatment at 5 years. Now we have the combination of both the BTK inhibitor and the BCL2, again highlighting how much progress we have made. With this in mind, I thought I will show you where we go further, because all the today's session is about looking for future. We know about the BTK resistant mutation. Hopefully, Anna discussed yesterday. But in terms of the financial planning and also the toxicity management and how do we keep people much better, is we need to move from a continuous to a time-limited therapies in the CLL. So with this in mind, I thought I should highlight the couple of the studies. One is the Captivate and the Glow, but which is the new kids in the block. So before I just wanted to show how much progress we have with the limited duration treatment and the longer follow-up makes. If you look at the blue line, which is the top line, the Kaplan-Meier curve, people who are having venetoclax, obinutuzumab, just over 50% are still in remission. If I had changed the curve without using the prognostic markers, you would have seen it will be even better. When I show you the survival curve for the GLOW clinical trial, which is using the combination of the ibrutinib and venetoclax, you can see, as compared to the chemoimmunotherapy, more than threefold of patients were in remission. This clearly highlights the red line is the people who received chlorambucil obinutuzumab, and the blue line is ibrutinib and venetoclax. I can understand the passion in which some of the advocates were arguing why they should have access to these drugs. You can see in 2025, if somebody is getting chlorambucil obinutuzumab, they have got a threefold less chance of being in remission at 4 or 5 years. This is frontline. Hmm? So I've only picked the frontline for today. But science progress, it never stops. Now we have the new combination, which is the acalabrutinib and venetoclax, because in GLOW, people had the treatment for 15 months, which is ibrutinib for 15 months and the venetoclax for 12 months, whereas acalabrutinib and venetoclax in this trial, patient had only had the treatment for 14 months, even a month less. And this is comparing to the chemoimmunotherapy or an access to the anti-CD20, in which case it is obinutuzumab. If I show you the progression-free survival, you can see combination only having the 14 months of the treatment. You can see people on acalabrutinib and venetoclax, over 3/4 of the people are still in remission after the completed at the 36 months of follow-up. You take the drug 14 months, and the benefit is prolonged with a significant progression-free survival. The question for all of us is what next? Because you have the acalabrutinib, zanubrutinib, and the ibrutinib, and people have a resistant mutation, the treatment stops. This is where we are moving from a covalent BTK inhibitors to the non-covalent BTK inhibitors. In the interest of time, I picked one of the drugs, which is the Bruin study, which is a randomized trial, nearly 120 patients in both arms receiving either the pirtobrutinib or the investigator choice. And you can clearly see with a median follow-up of over 20 months, the patients who had pirtobrutinib, which is the non-covalent BTK inhibitor, almost doubling the time they're in remission. And the most important, the time for the next treatment is as compared to 11 months with the other treatment, which is 2 years, 24 months. So there is hope and opportunity. I'm sure majority of the countries, we still don't have access to the pirtobrutinib, but this is what the network should fight for, so that we all have access to these excellent drugs. We're just not stopping at looking at the small molecules. The clinical and the research community is working hard to look for other options. So now we had BTK inhibitors and both covalent and non-covalent BTK inhibitors. But the future is about the cellular and the T-cell engagers. This is a CAR T, and here, because of the longer data, I'm showing the data from one of the CAR T called the lyso-cell. These are patients who are multiple lines of treatment. Once they get the CAR T, you can see how much response, and not only achieving a clinical response, but also MRD negativity. This, for the benefit of the people in USA, it's approved by the FDA, but rest of the countries, we are still awaiting both approval and also access, which is funded. But it clearly highlights the future is bright and the future is orange, because this cohort of poor prognostic patients, 9 out of the 10 who entered into the study had some response. We have failed the drugs, maybe the covalent and non-covalent BTK inhibitors. There is a hope in terms of the BTK degraders. And again, there are multiple BTK degraders, and at least the 3 which are different pharmaceutical. One is the Nurix, the AbbVie, and the B1. So those 3 BTK inhibitors are in advanced clinical trials, and hopefully they may be available for routine clinical use in the next 12 to 24 months. We're not just stopping at the different small molecules. The land of lymphoma, there is access to the bispecific treatment, which have revolutionized the treatment and given opportunity when everything else has failed. Similarly, for patients with the CLL, we do have the opportunity of bispecific, particularly the data of the EPCOR looks very good. And with the interest of the time, I didn't have the opportunity to look at some of the special situation in CLL. One is the Richters, and again, for the Richters, the bispecific may make a huge difference in terms of the treatment options. Now, it is good that we have access to the wonderful drug, but what really makes the simple things do take a long way, and this is where some of the work from the Birmingham, which is very important, is the vaccination. And I think if there is one take home for the network and how do we empower the people, is this is where I was very impressed with the Thai's website showing the vaccination, the prophylaxis, and again, empowering our patients, making sure they all have the COVID vaccination. And to a great extent, the CLL community is following some of the work already done by the CML community. How do we look at the risk from the point of the cardiovascular? We optimize, we look our patients to look at their blood pressure, look at the cholesterol, and how do we optimize. These simple things do make an impact in addition to the more important drugs. But highly likely what the future will be, again, UK led this in terms of the FLAIR clinical trial, where rather than giving the treatment for 14 months or 15 months, which all made maybe with some assumption, will be going towards the MRD directed limited duration treatment. This will make difference in terms of the majority of patients may not need their second line treatment because you've done the treatment based on the MRD. The next is, can we do, again, we follow our colleagues in myeloma, because in myeloma, people get a much more intensive 4-drug or 5-drug cocktail, whether the CLL, particularly the poor risk, may be served by the triplet. And the most important is somebody highlighted, it must be data, data, and data, and the information is the key. And this is where we don't have many of the countries participating in the clinical trial. Getting the data is very important, and particularly the real world data. Hopefully, with some of the things I've shown, maybe we have an operational cure for CLL, because whenever when Ross was told the diagnosis just before his 40th birthday, somebody must have told, oh, this is an incurable disease. So it must be very challenging to accept. But I'm hoping with what I have shown, we are moving towards an operational cure. And I wanted to leave you with these are the messages. Whatever we do, the diagnostics is very important, and I think learning the prognosis is the key. Highly likely we'll be moving away from the continuous treatment to the time limited and more likely MRD driven, because financial toxicity is as important as the toxicity from the drug, because majority of the countries have to cope if we have to have access to everyone with the CLL. So that is why, and we have plenty of novel agents and more to come. I again go back to Donald Rumsfeld, unknown. So I don't know what may be. So when we come back in 5 years' time, there will be a few drugs we never thought of at this stage. But as some of the website and what the network is doing, and I think we can only get the best outcome if we have the holistic approach. So I think holistic approach, doing the vaccination prophylaxis is key. I think the most important is lunch. I don't want to delay if.
Don't make the lunch, we're keeping them in the room.
Okay.
A few more minutes. That was fantastic. What we're going to do now is we're going to bring two patient advocates up with their experience, one from Armenia. So I'm going to introduce them. We're going to put the chairs out for a panel discussion. So I'd like to welcome Arman Vardevaryan. I hope I pronounced from Armenia. He's an advocate dedicated to strengthening patient support and advancing cancer care across Eastern Europe. And Ron Moskovitch from Israel, a patient advocate sharing the lived experience perspective on how new treatments change daily life for those affected by CLL. And I think after seeing that session and then to hear from the patients, and then we'll open it up to the floor for a conversation. I'm going to put the three chairs across. Okay, so I suppose to bring the patient advocate voice into this CLL treatment story and the options and all. Ron, maybe do you want to share some of your story? And
okay, my message is hope, and I share my story. When I get the CLL, I have two ways. One to sit and cry. And maybe the CLL, it is some big clue to change my life. And I prefer the second option, and I change my life with two dimensions. One is from the soul, and the another is from the body. Yeah, I change from the body. Before 3 months ago, I finished a marathon, and I make exercise every day to keep my body. In my soul, I am mentor in my organizations, and I have a patient, 32 patients, that I support them, and I am an angel for them. Because in a short time, I want to share you some comment that I get before 1 week. You for some employed, some patients, you have no idea. Our surgeons is to have on the other side of a person writer an angel who know how to listen, support, and help the execution of the rights in the front of the various authorities, who has a sense of humor. You brought back the color to my face. Bless you, dear person angels. This message is how much it's care to mentor, to support for everybody. That's it.
That's great. Thanks very much for that, Ron. Arman, talking from your own experience in Armenia, and I know that you've gone from a country that probably had no access, and I think there was work with the Max Foundation to bring maybe a targeted therapy, and we heard from the doctor talking about that, trying to get access for these targeted therapies. What would you have to add?
First of all, thank you so much for this opportunity. My name is Arman Vardevaryan. I am a residency in hematology and present doctor. Not yet a doctor, but I will be. Hope so. Also, I'm a fitness trainer and want to add that in our country we have a financial issue that we don't have medicines to provide, and Max Foundation are providing us a Brukinsa for 32 and more patients, and thanks to them for this opportunity. And also we have a diagnosis problems, like it's taking too much time to have like results, because we are doing IGHV mutation abroad and we are waiting for the answer too much time. We are sending it to Russia in order to get the results. And that's all I will add.
So
thank you so much.
I suppose the what's kind of been highlighted to me is, even though I mentioned that there was access to a drug, there's still major problems, and it's access to the diagnostic
Yes, exactly.
tests. And yeah, so and I suppose I'm really delighted that you mentioned, Doctor, about the patients trying to get access to these treatments. And I suppose I can sit from a high income country and see the great hope that there is. And whether it's going to be a combination treatment or a triple, and you brought it even a step further, and we don't kind of have the answers of what the best treatments are. But what advice would you give to patient advocates I suppose, and even from the IWCLL and that network, and what we can do for the wider world for access to these treatments?
And I think the key is collaboration with pharma, somebody mentioned, then the charities like the Max Foundation. And again, Emma was very articulate. I don't think we can anywhere compete with her passion. It's about the legislation. How do you enable all these people to come and work? And in terms of the discussion with the patient, because every patient situation is so special. Sometimes this is why it is a personalized decision making, and I think empowering the patient. And this is where I did like the Thai website, where they have provided the information linked to all the data, and again choosing what best for patient. And the role of the clinician is to enable that information, and again with the medical history guide patients what may be the most optimal treatment.
Yeah, and I suppose it's difficult for them doctors that work in them jurisdictions to know that they would go to EHA and they see the kind of presentation that you put on and all these, but they go back to their countries and they see their patients and they can't offer. I don't know how they. Has anyone got anything that they'd like to ask?
This is just a simple one. I think Michael's alluded to in a first world country. One of the things that we're certainly able to talk about is, a patient diagnosed today, by the time they may need treatment, they're going to have other solutions, and it just gets better and better and better. Arman, how do you deal with that question of hope and a question of the future? It's growing, but you're in a limited region.
Thank you for the question. I want to say that it is much better to give the opportunity to low-income countries to take the advantage of the medicine and the treatment in order to help patients of CLL. That's all I can say. Only support from others, because we need help. This is all I can say.
How do you give patients the hope message?
The hope message, like inspiring them to live. In my way of working, I'm a fitness trainer as well, and I just inspiring them to work hard, to work their muscles in order to gain a kind of energy. and never just give up, just go forward, because life is beautiful, and the only hope is over here inside your brain. You are your treatment, I'm telling them.
Ron keeps telling me to go jogging with him at 5 in the morning while he's been here. No thanks. That's, yeah, I know. Yeah, well, I suppose maybe I should take his advice. Ben, do you have anything to?
Yeah, I did, and thanks very much, everybody, and Paneesha, it's great to see you, and thank you so much for sharing this data, which can sometimes appear very complex, but the key message, and we've heard it so much today and over the few days, is the message of hope that data brings, and it almost, you can see through the numbers, and the message of hope comes back to us. But I think we need to be aware, perhaps, of how complex this human characteristic of hope can be. It's a real thing, and it's a measurable thing, it's a tangible thing, and it can be unpacked in different ways. We often say or think that it's something that is more applicable to our patient group, but I think it cuts across the board. It is so human, and it is something that is applicable to clinicians and to researchers as well. So hope, and I was just reading about this, and it can be broken down into some key strands that in itself, it is that energy force that Arman, you were talking about. It's
Yes.
something that you build in yourself, a resilience in yourself, but it can also be seen as an agency that you create in your heart, or through the community around you, through the support that you get, and it's those pathways to care that you create yourself and through others in the community in the CLL community. So my wish then is for everyone to grow that sense of determination, pathway building, and agency, whether you're a patient, carer, or clinician, or researcher.
Yeah, and I have to say that at any time I've come to these sessions, sometimes when you're meeting other oncologists for other diseases and all that, and it could be so dismissive of CLL. So I love coming to this and meeting the clinicians, and you're so passionate about CLL, and you actually realise the difficulties that the patients, even when they're on that active surveillance and their bloods are normal, but they still have difficulties, and we're trying to address that. I've often wondered when I'm involved in CLL advocacy since 2011, so chemoimmunotherapy is all we had. So, and then we only had one BTK and one BCL that were coming, so the choices were very limited, but easier choices for a doctor. And I'd asked this question at a conference a few months ago: is that how do you make the decision on what you give a patient? That's when you have such a choice, probably in the UK, but.
I think this is where the data is power and data is knowledge. And based on the information, we do know some BTK suits for some people. The safety profile and the toxicity profile, you'll be able to make the decision. And some people's condition may not make them suitable for BTK inhibitor. Like if somebody has got a mechanical heart valve and they can't have BTK inhibitor because they have to have a warfarin, in that case, now we have the BCL2 venetoclax option. This is why it is the individual decision making which comes into picture, where you discuss with the patient, go through the data, and again, the choice between a continuous treatment and a time limited is to a greater extent dictated by patient preference. Because if the data is very clear, it is very easy. Sometimes the data may not be very clear, where the patient choice actually trumps. So this is why active discussion, and you come with a personalized decision making suits that particular patient. So that is why it is making this decision over 1 or 2 visits rather than just making, sign the consent form today. That may be the best approach to get to the right treatment for that particular patient. And the key is regarding the hope, even when you are we used to call watch and wait, people would interpret as watch and worry. During that time, I think we need to say the importance of the vaccination, the prophylaxis, and hopefully that will raise hope. And in all this, we also need to think the CLL is the one condition where we have made a difference to the national history. If you go back to the previous millennium, about 15% of the patient would have diagnosed CLL when they presented to the clinician with symptoms. But in 2025, less than 2 or 3% of the CLL diagnosis is made because patients go to a clinician with the symptoms, because we go get a routine blood test, which is for something completely different, and the CLL diagnosis in over 95% of the patient is made that way. That is why of all the patients we diagnose CLL, a good proportion may never need the treatment. And I think this is what we need to highlight to the, as far as the CLL is concerned. Science is evolving, and this is where I need to big up Birmingham and the Leeds. They're working whether they can identify a patient with a very early CLL who may have a combination of treatment for a very short time, and which can change again the national history, and their immunity get back to normal, and they may never need a treatment for the CLL. These are the things to look out for future.
Yeah, that's fair. It was actually, as I was sitting there, I was aware that we had Ron, a patient advocate, coming up, so I was trying to think of the questions that I could ask from a patient to a. And Ron, I do have a question for you, but that question about that early treatment, I know we always hear that no, you do not treat a patient early, but I'm wondering when I'm looking at these degraders, and I know that a lot of the clinical trials, when I looked at patients that have multiple treatments that are going on these trials, and I'm wondering what will these degraders do to an early CLL patient, and are we looking at curative? But that's maybe my wishful thinking and my simplistic,
A great question. I can only tell what we have the evidence for. Again, Steve Debro from King's did a study of looking at a cyclosporine, and it did not make any difference for the early CLL. Then we had ibrutinib. It did not make any difference. But now we have opportunity for the second generation BCL2 inhibitor, whether we can identify a cohort who may because it is balancing the side effects versus the toxicity. And again, what you don't want is to convert people into patients. So that is why CLL is just because people go and have a routine blood test for something else, and the CLL is diagnosed. That is why it is possible maybe in few years' time we may have a cohort who can be with a limited duration early intervention. Again, natural history may be changed, and we may understand how we can optimize the immunity in CLL cohort.
It's really interesting. And Ron, I suppose as a patient and an advocate and all, and in your own choices and all, that, we spoke about this earlier on about resilience, and if you're a patient and you're on treatment, do you be thinking about the next treatment, or do you be thinking about relapse?
Yes. Yeah. First of all, I want to speak. The message of the organization is to bring to all the patients the news. We have many tools with webinar, with WhatsApp, Facebook, and some conferences. But the message, the very important message that to this time, it's very new, because we have a solution for the first line, the second line, the third line. It is very up. The patient said, "Okay, I tried about a few years. What happened? Don't worry. We have a second solution for second line, for third line. Enjoy for the life." That's it.
I think it's a good, and I didn't mean to actually put you on the spot with that question, but I'm often thinking, I'm not a patient myself, so it must be difficult for patients to know that it's maybe second line, a third line, a fourth line, and they keep having to consider and going to these sessions. I want sixth line. Was that hand up? Do you want? Yeah. Does anybody have any questions that they'd like to add, or? I think that's what happens when everyone gets hungry, you know. Well, look, sure, the clock is running out, so I would just like to say I really appreciate, and what I'm going to do actually just before we close up is hand over to my good friend Jana, who has some closing messages, you know, and thank you all for.
Thank you too.
Thanks.